He's a very good director, okay. 2 people contested. 1 person won.
To hear. Not saying I'm not even allowed to set line. I don't know how true that is.
Same doctors that you said had no depth of those knowledge.
Okay.
I don't know that will teach you those farm care.
Now, they say that it's because they call it medical director, so it's for medical students.
Guys, welcome back to my YouTube channel. My name is Abiodun Rufai. I film videos about pharmacy school, my faith, my lifestyle, and school life in general. If you are new here, welcome. Make sure you check out my other videos and do how to subscribe before leaving. If you are not new here, thank you so much for coming back. I appreciate your love and your support on my videos. So straight to the business of today. As you can see by the title of this video, we'll be doing something totally different. The title of our video is The Battle Between Medicine and Pharmacy. So low-key, if you're a medical student or a medical doctor, a pharmacist or a pharmacy student, you know about this underlying battle that we're going to talk about here today. In the video of today, we're talking about the root cause of this problem, our reality here in this school and in the field, and we'll be providing solutions to foster a better relationship between medicine and pharmacy in school, in the field, and beyond the field. So if that sounds like something you're interested in watching, stay tuned.
And of course, I think one other gap in knowledge I've come to realize from my interaction with even some medical students is the fact that a lot of them don't understand that we do more clinicals than they even think we do.
How many semesters?
We literally do clinical pharmacy from 200 to 500 levels.
So does that mean that you guys do the same course?
No.
At every...
No, don't get me wrong. I didn't say we do as much clinicals as doctors. I said that a lot of them fail to understand that we do more clinicals than they think we do.
I'm now asking that.
Okay.
How much of clinicals do you do?
I just said we literally do clinical pharmacy for 8 semesters.
Do you mean you do in bits or they are crux of
I told you the way pharmacy curriculum is. We literally spread what you have to learn across the years.
Of course, normal.
You understand? So it's it depends on what you mean by the crux. Because yes, we do everything down to the crux of what clinical pharmacy entails. Maybe not as much pathology as you do, as much as you don't do as much pharmacology as we do. You understand? So we might not be able to.
But okay, I'm tested on all aspects of pharmacology.
I agree. Okay. But it's not as deep as what I do.
If I'm tested on all aspects of pharmacology, then what else? What's deep? What else?
There's a depth of knowledge. You understand? There's a function. There's a span of knowledge and there's a depth of knowledge. You get? So yes, you probably will touch every topic. You understand that pharmacology at the undergraduate level can offer. But then, what's the depth of those topics? I don't know if you understand what I'm trying to say. Okay. I would do anatomy. I would do physiology. You understand? Just bit across board. But I can't compare. I can't compare what you know in those areas to what I know. Do you understand what I'm trying to say? And it's the same thing I'm trying to say when it comes to pharmacology. You do pharmacology for many years.
I do pharmacology for 9 months.
9 months. I do pharmacology for 4 years. Oh no, sorry. I do pharmacology for 3 years.
You do? No, that's not. If I'm glad that you're bringing this up.
Okay.
You do pharmacology for 3 years.
Okay.
You do all of pharmacology in 1 year, all again in 2 years, all again in 3 years, or you do any bits for 3 years.
That is what I am saying. That there's span of knowledge and there's depth of knowledge. So if they are taking you, say, cardiovascular drugs, you understand, and they're taking maybe cardiovascular drugs for maybe, I know they can't take you cardiovascular drugs for 3 months. I don't know. No, probably I don't know how long.
Everything, of course, the entire thing is about 9 months, about 6 months here.
Okay. And then I'm taking a whole semester of cardiovascular drugs. Do you think the depth of knowledge will be the same thing?
Good.
Did you get?
Hold on, sir.
Okay.
It might not. In fact, in terms of I don't even want to say that it might not, it would.
Okay.
The thing is this: are you being tested beyond the cardiovascular that you've got in the curriculum? Because it seems that you learn more of those drugs in maybe cognosy or in other parts of your curriculum, or within that same pharmacology that all of us are doing. That
now I think that's another mistake. All of us are not doing the same pharmacology.
The others are doing that.
The pharmacology department is taking you pharmacology. What we are doing in pharmacy is pharmacology and toxicology.
Okay.
You're doing pharmacology and therapeutics. Maybe in time past it was the same, but now it's not. You understand? So now I am doing cardiovascular drugs, for example. They are taking you the ABC and the other kind of drugs. You get? But for me, aside from that, I am also still bringing pharmacognosy into pharmacology. Because I am bringing the chemistry into pharmacology.
Are you taught all those ones to inside pharmacology?
Yes.
It's pharmacology department that teaches you
exactly
the cognosy in pharmacology.
Exactly.
So
okay.
You know there's a department there's pharmacology department.
Yes.
So are you saying that while you are doing pharmacology, that the same that today we are doing pharmacology of CVS drugs?
Okay.
So after you are taught that same class,
okay,
they now look at the cognosy of it.
Now,
chemistry of it. I be when you get to those other departments.
No. Now, don't get me wrong. There's nothing like, okay, now we are doing the cognosy of CVS drugs. No. But I'm saying they are bringing, some of these things we have learned in all these other ones. I mean, pharmacology lecturers now. And then are bringing it into pharmacology. You go ahead and you do structural activity relationship of CVS drugs.
In pharmacology.
Okay. And so, I would be able to tell you the reason why you can use metoprolol and not atenolol. You understand? And in what condition this will work faster and not this? Why I would rather prefer you prescribe this than this. Some of these details doctors don't know.
And what I'm saying, I did not knowledge that you gained from pharmacology or from family. Because now, what I'm saying is this. There's something I want us to understand.
Okay.
The reason you have this knowledge,
okay,
is it because you do more pharmacology,
okay,
or because you do other parts of drug, or whatever,
okay,
maybe in cognosy, in pharm chem, in everything, you are doing other parts of drug studies,
okay,
like all those ones, or because even in that your same pharmacology, you do, because it's something that we also understand. Is that time we stopped, some funny, I don't know, okay.
When you get to pharmacology, you understand, they would go as far as telling you, okay, this is how digoxin works, which is basically what you guys will be taught. You understand? But then they still go as far as bringing the chemistry.
In pharmacology?
In pharmacology.
Oh.
Yes.
I not taught by doctors too.
No, we have some doctors that teach us. So you understand? But most of our lecturers are pharmacists.
I know. Of course, the same people that who teach us.
Okay.
So is it the same, for instance, the ones that the doctors teach?
Okay.
The same doctors that you said had no depth of those knowledge.
Okay.
And not that will teach you those pharm chem.
Now, the question is this: there's always a difference. There's always a difference in when doctors take us pharmacology and when pharmacists do.
Okay.
You understand? And any pharmacy student you at least here will agree with that. And yeah, I mean, there's some things we can't say on camera. You get, but in many other schools, you would hardly get medical doctors take pharmacy course. I'm not saying they are not.
Of course, I do.
You understand? But you would hardly get. But then, when you're talking about a medical doctor taking pharmacology, he is not taking it with just the knowledge of MBBS.
Definitely.
Do you understand? So this is somebody probably that has done his master's and PhD in pharmacology, which means there is an additional knowledge that is coming that has gone beyond just what he got from medical school.
Sure.
In the process of doing his master's and PhD, probably get pharmacologists that would have taught him. Some of them probably would have been pharmacists.
No,
Do you understand? So, in the process of him being taught by pharmacists, some of this knowledge would have been imparted to him. You understand? There's also the place of research on his part, which means he must have delved into the world of pharmacy to learn some other things. You understand? But what I'm saying is based on the crux and the core of what you are taught as pharmacology, in pharmacology, in your undergraduate medicine, and what pharmacy students are being taught in undergraduate pharmacies, pharmacy now, there's a variation in the depth of knowledge. You understand? And that is why the way you will look at some drugs, even as a final year pharmacy student, will be different from the way I will look at some drugs. You understand? There are some things I would start saying about some drugs that you might not be able to relate. And that is not because you are ignorant. No. It just shows the difference and the variation in fields. I don't know if you understand what I'm trying to say. So it's that. Your anatomy is deep. Your physiology is deep. Mine is not. You understand? But my pharmacology is deep. Yours might not be as deep as mine. You understand? My biochemistry is deep. Yours might not be as deep as mine. Do you understand what I'm trying to say? So there's those variations, and these things, these differences, directly or indirectly affect service delivery. So which I feel it is something we have not started exploring in this part of the world yet. I don't know, I may not have some raw facts at hand now, but I believe that there are some countries, you understand, or some states even in the US where doctors basically do diagnosis and pharmacists do prescription. You understand? So it's just the variation in knowledge. And I feel like another fact we really need to start considering is the fact that even though that may not be the ideal, it is still the reality that most times pharmacists are the first point of healthcare in Nigeria.
Of course.
Do you understand? I'm not saying it is the ideal, but it is the reality. And in countries where things work, for simple ailments, most times people get it solved in pharmacies. Simple ailments like cough, cold, basic stuff. Even in countries where things work, pharmacists manage diabetes and hypertension. They might not be the first point of contact, you understand, but they play a major role in the management. Do you understand? So all these factors are still things that in this our own particular health system we have still failed, you understand, to explore. Maybe because a lot of people still feel like there's a limit to the knowledge of pharmacists or to how much of clinicals pharmacists knows. And so we are failing to explore those things. There's even a new branch, maybe not so popular here, but I know a lot of pharmacists are exploring it, and that's the herbal area of pharmacists. A lot of pharmacists are already making use of herbs, to manage some conditions that orthodox drugs in quotes seemingly are not handling. It's not popular yet, yes, and probably due to what's the word now? the handicap system we have in areas of research and other things like that. So you cannot boldly come and say this works and that works because you've not been able to carry out some evaluations. But are they using it? Yes. Are they working? Yes. Who have all this knowledge? Pharmacists. Do you understand what I'm trying to say? So these things I feel like are things that we still need to explore. And as much as we feel like no, there's no policy on ground, there's no this, there's no that. We know that the politics is a major factor. I'm not saying pharmacists don't have their blame, because if we delve into that too, that's another ball game and the whole discussion on its own. Do you understand? But I feel like the lack of insubordination in the healthcare system is coming. I know you will not agree with this, but I feel like there's still that problem from the side of the doctors. Other health professionals have their issues, but I feel like there's still that problem, that sense of no, we are the ones there or something like that, which I feel like most health professionals agitate against. It got to my hearing, I don't know how valid it is, but I got, from a relatively reliable source that even in our hospital here, nurses are not even allowed to set line. I don't know how true that is. You understand? So, and I'm like, really? I'm not a nurse. But I feel like that should be part of their job description. I don't know. So, and these are things that are obtainable in many other spheres. And even in this Nigeria.
The question is, do nurses want to set line?
The question is, if it is part of their jurisdiction, would they not?
The question is, are they willing to set line? Is it part of their job description?
Now, that is the question. I am not a nurse.
Neither am I.
So, but I just told you what I heard. And I know that in some other climes, at least quite a number of other hospitals, nurses do these things. You understand? But that's not what is obtainable here, based on what I heard.
Yes. I'm trying to just quickly that here that if it is not part of the official job description, then we got not to blame doctors that
but the question is, official job descriptions where? Is it here or job descriptions generally as a nurse?
No. the question is this. Are there, everything is about ranks.
Okay.
As a medical student, for instance, if my chief is there,
okay.
Yes. If my chief is there, normally my chief would set the line, okay, because for patient safety.
Okay.
So, you see that they were supposed to be the next in line and they were not allowed to do it. Okay? I know nurses here, okay, that said at least I know the one that said like in my presence before.
Okay.
Yes. So I don't know. That's one of the things that we have to understand. There are lots of things going on. There are lots of rumors going on. I'm saying that there's a lot of things against doctors or this that. But in as much as we want to prove our points, we also have to understand that these things, you do a double check of your facts. You get. But I let that you said that was what you heard. For you to have heard, 1 million and 1 people have also heard. But nobody will tell any nurse not to do whatever is within their job description, at least as stated by the Nigerian Labour Service or whatever.
Okay.
If it is within the jurisdiction in the Labour Service, and that's what you also have to understand is this: the job descriptions just also differ by the level of healthcare that you are in.
Okay.
So as a doctor, what I would do in an health center, okay, with my level, I won't be able to do it in a teaching hospital.
Okay.
In an health center, for instance, I can as a young doctor, okay, make cash babies. Okay. Yeah. But in a teaching hospital, it has to be maybe a midwife or an obstetrician. Okay. Yes. Not because I cannot do it, but because it's a teaching hospital, there's a level to come allowed to do that level of healthcare. And that's what I want to understand. So it's not a matter of doctors trying to do this or thereabouts. I think it's just like quickly clear off their head.
So I think that's basically it. You understand? Yeah, so all in all, I feel like the system also plays a major role. Yes, we blame doctors for quite a number of things, but I also feel like the system also plays a major role. Like I said before, if we are to delve into some of the downsides, you understand, of even the pharmacy profession, we're not here today. I don't think I'm even ready to talk about that. You understand? But all in all, I just feel like we understand the fact that this thing is more of a teamwork than a competition. You understand? We holistically help the patient better than whatever form of satisfaction we tend to derive, from what we think is a competition.
Yeah, thank you so much.
Thank you very much for such a long take. On that point. So the next question is, we all know what happened between medical students and pharmacy students in our school. I think it was last year, on the position of medical director, who is not going to be medical director. So briefly, tell us what's your perspective, what you saw from your own perspective, and what should have been.
Okay.
So,
Do you know
Go first, please.
Each of very good director, okay. Two people contested. One person won.
that's what you saw. Please,
What else? And if the constitution of the SUG says that anybody
Shagam campus.
although I have a submission to that,
Okay.
yet the question is, at that point, at the time that the constitution was made, yet what campus was the Shagam campus? Yet, you know, we had the Kenya campus, we had Shagam campus.
Okay.
So, in fact, that was like, you know, now people claim that all the three campuses, all the three faculties are eligible. So the question is, at that time when the stuff was made, do we have all the campuses
Together in Shagam.
Shagam? But since, you know, there's something we say in politics that the Senate President is the custodian of the law.
Definitely.
If Senate President interprets it as, okay, now all the campuses in Shagam are eligible. Two people contested, one person won. Whatsoever happened in-house that caused whatever will be solved in-house. So two people got contested, I said, one person won. And the person said anybody can. And that's what I've got to say.
The UNSA president is very political and I like that. Okay, so I would not say so much. I would not even point fingers or anything because I feel like we've relatively resolved that issue in-house to a reasonable extent. But what I would just like to point out is the fact that I would try to reiterate what he has said before. And I think the major problem here is the problem of interest, like I said before. Pharmacy students have their interest, medical students have their interest. PANS had its interest, OOUMSA had its interest. Maybe the way some individuals went about it then, you understand, was the major challenge, and I felt that was what didn't go down well with me. You understand? Because I feel like the whole rank herself, to a reasonable extent, I think I was part of the instigators, you get. But I feel like the points I felt we should make, we've made it. You understand? And I feel like everybody is cool now.
Which was?
Which was the fact that, like you said, it's opened to everybody in Shagam campus. And two people contested, one person won. Do you understand? Because the what was flying around then, do you understand, was the fact that this thing is supposed to be the one faculty. In fact, some people even went as far as saying that it's because they call it medical director, so it's for medical students. You understand? And the question I ask is, what do you call, what's the definition of a medical student? You get? Because when you come to Shagam, they will tell you it's Obafemi University College of Health Sciences, which means every course in Shagam campus is an health science course, right?
Pharmacy is not under the college, you know.
Pharmacy is not under the college.
Yes.
So pharmacy is a faculty on its own.
Yes.
So it's not under the college. A faculty is not supposed to be under the college.
In fact, pharmacy, now, according to the organigram of the university,
Okay.
pharmacy stands on its own.
Okay.
The College of Health Sciences.
Okay.
I'm not relating this to.
So yes.
Listen to pharmacy stands on its own, and the Obafemi College of Health Sciences has just two faculties.
BMS
Faculty of
and
Basic Medical Sciences and the Faculty
clinical
of
pharmacy and clinical science.
And that is why the provost can only be from either of those two faculties.
Okay.
Either basic medicals or clinicals.
But
But if only from pharmacy can never become people.
But does the decision of the provost not affect pharmacy?
It doesn't.
It doesn't. In any way, so the provost doesn't have any jurisdiction over anything that belongs to pharmacy.
The only thing is just that the provost, in terms of ranking,
Okay. Is higher than the dean, and that is at the level of the university.
yes, but the provost does not have any binding power
On the faculty of pharmacy. Okay. I appreciate that clarification. But like I was saying before, it was the whole saga was a clash of interest. I wouldn't call it a power tussle, but it was more of a clash of interest and more of making a statement. And I feel like we've really literally resolved, that issue. Because even what instigated the whole rancor, we've solved it, we've sorted it out and everything.
which was.
Okay. And so it was a voice note that was trending at some point. I don't know if you heard it.
So the question is, why then did people decide to pull out the opinion of one person and lock that on the mind, lock that around every medical student?
Good. Now,
Why did you decide that a person,
okay,
a single opinion is a sample of
everybody
about 500 students?
I agree with you. You understand? What I also felt like OOUMSA should have done when that whole thing was trending was to actually probably release a disclaimer. So this is not the stand of the student body on this issue. You understand? We don't share this perspective, and so we don't want everybody to think that perspective. I feel something like that would have just, doused the whole situation. But of course, some medical students, of course, not all, because I didn't get to hear everybody's view. A lot of, a reasonable amount of medical students shared the perspective of that other person. And I feel like, of course, when one gist goes to the second person, third person, before you know it, it goes out of proportion.
Okay. Now, let me just say this. Well, of course, I was not the OOUMSA president.
Yes, you were not.
But even at that, I still believe that, OOUMSA does not owe, an association does not owe anybody an explanation.
I agree.
Except you write, let's say you have a formal, okay, that this is happening, that, what is the stand then? But in that case, an association does not owe anybody an explanation.
I agree.
And they're also saying that a reasonable amount of people get, number one is, we have to do in OOUMSA. We have people that are really politically oriented. Okay. We have people that are indifferent. Okay. And we have people that, even though they are politically oriented, they just go on their own. But when it comes for them, they will just come in when needed. Okay. But some are fully and some anything. So, and people that are indifferent are the most that you have any political stuff. Yes.
People that are indifferent.
People that when it comes to SCG politics. Most of your sites are indifferent.
I agree with you. I agree with you that most of your sites are indifferent. But I just want to point out something. Mm-hmm. Now, if as much as I know that a minority doesn't represent the majority, I think you will agree with me that there's what is called influence. You understand? Now, I would not mention names, but I feel like if some people talk, you understand, there's a high probability that the majority of generality of students would say this is medical students.
It is the majority of people that are in their clique. I know what I'm saying.
I understand your perspective, but I just want you to understand what I'm trying to say. That there's I'm relatively influential in my faculty. You understand? And there are quite a number of other influential people. You get? You guys have of course, both faculties have what you call stakeholders. Sure. And you know that these stakeholders are people that are relatively influential. A word or two words from them can affect a whole lot of things among the student body. You get? So are you going to say that if these stakeholders are talking, as much as they might not necessarily be representing the opinion of the general populace, are you saying that whatever they are saying should not be held as weighty? I don't know if you understand what I'm saying. So if that's the case, like I said, I agree with you that OOUMSA doesn't hold anybody any explanation. You understand? But what I was just saying was, if at all that situation had gotten to OOUMSA, or you feel like it was painting OOUMSA in a wrong picture, in quotes, I felt like the best OOUMSA would have done, or at least the least they could have done, was release something to exonerate the association from what's doing. Okay, some students are the ones that have this view. This is not the view of the association.
I understand your point.
You understand?
It still remains that OOUMSA as a body, like I said, I was not the president then. But even at that, I am still not saying that I'm not placing any blame on the past.
I am not doing that
because
too.
they owe nobody.
I agree with you.
I think the formal complaint that we heard this and this that and they try to decide to keep quiet in that case. Yes. But since there's nothing like that, it was just fully political. I
agree with you. Don't get me wrong. I'm only saying that because you were saying that some students some minorities cannot represent the entire.
They cannot.
And I'm not disproving that. You understand? But now, from when all this issue went around, I don't think in any case anybody had mentioned OOUMSA as an association. I don't think so. At least to the best of my knowledge.
That's why you should not generalize.
You understand? And so, but what I'm just saying is that yes, you say we should not generalize the medical student. But I'm only trying to make you understand that you still cannot remove the fact that when some people talk, you can't avoid you can't stop people or the generality of the student body in the campus now to think they are representing the generality of medical students.
So would it also have been right because medical students are not the only ones that had issues with some speeches. Okay. Of course, I heard quite a lot also. Okay. I saw that happened. Okay. I heard and I saw things even from pharmacy students. Okay. Get. But would you have been right to to now say that that's the view of the generality of pharmacy students? What I'm just trying to say is this. See, the personal opinion of people should not be taken as a total representation of, and that is one thing that escalated the whole thing.
The whole thing, I agree with you.
You get, face whatsoever it is that you think said whatever, and in the long run, people that said whatever they said, and people also from your own side also said a lot of things.
Definitely.
You get, good. And because of that, nobody took that as that's what pharmacy students, and if people took it as but now both people that said something in your own place and people that said something in this place, now politics is gone. All of them, many of them are together. Whether by eye service or by whatever service. You get. So what I'm saying is that two people contested.
Sure.
One person won.
Definitely.
Now whatever it is that happened in between, yes, it's just as good as anything that politics could have brought.
Of course.
Which I think should now not be taken as the representation of the generality of the medical.
Sure.
This is just like a cross-sectional stuff. You cannot generalize it. You get those people that say those things. They are like in terms of the number, they are minor. When we talk about politics, they might be strong forces in politics. But the fact that you're strong forces in politics does not mean that people would totally. The way people will follow politicians in the secular what's called in partisan politics, because these politicians fit them. These politicians do things for them. These politicians they give something like baits to aim their reality. Nobody's fitting anybody in OOUMSA. So you cannot generalize people's opinion that is what everybody has said and that's what everybody will believe. That's what I just want to clear. But in terms of the director, like I said, 2 people contested, one person won.
Okay.
Either whatsoever it is that happened that brought about the winning of one person or the loss of it should be settled in-house.
Which has actually happened. You know, like before I even started talking, I said it.
Sure.
That most of the issues that came up have actually been settled. I mean, even the person in question probably created all these weird good things we talk and all.
But that's what about high science or whatever?
That's great. You get it. So, but what I just wanted to clarify is that as much as one person cannot determine for the entire association, we should not ignore the fact that the voices of some minority are actually very loud and be misrepresented for the voices of the masses.
That's what I'm saying. They are loud within the level of their influence.
Because even when you flip it to the other end, to pharmacy too, there are some people that will say some things that, okay, maybe pharmacy as a department might not even have such direct issues with medicine. You understand? I mean, faculty of pharmacy direct issues with medicine, but we have such issues with BMS to a reasonable extent. And you will get people from BMS say things like, our pharmacy will survive, our pharmacy they are proud, our pharmacy they are this and that. And then you and average pharmacy then start recounting how many friends you understand you have in BMS, or how many of your flatmates and roommates are students of that faculty that you guys roll together. But then you're not like, how would you now say you are proud? Do you get? So it's just because a minority have that perspective, and then it's just easy for people to just believe that, it's the representation of the majority. So I think that's actually one thing that was in play in that scenario too. Okay.
Alright. Thank you so much for all the violence you have shown me in this video. So lastly,